presented to us. Case 1. A 22-year-old primary gravida with 38 weeks of gestational age referred to us in view of deranged liver function test and abnormal coagulation profile. Her chief complaints were loose stools and vomiting since 15 days and abdominal pain on and off since 15 days, fever with LOS, discoloration of eyes since 3 days. On examination, patient looked pale, icteric and anasarca was present. Her vitals were BP 110/70, pulse rate 100 per minute, saturations 96 on roommate. On per abdomen examination, uterus appears term gestation, relaxed cephalic presentation with fetal heart rate 90 beats per minute on handheld Doppler. Growth scan findings were 2 to 3 weeks growth disparity with oligohydramnios with fetal heart rate 100 beats per minute and mild maternal ascites was present. On pervaginal examination, cervix 30% effaced, os admitting one finger, pelvis was gynecoid, and foul-smelling vaginal discharge was present. Her laboratory parameters were like this: HB 10.4, WBC count 42,900, serum bilirubin 10.1, elevated liver enzymes, INR was 4.8, serum creatinine was 1.6, GRBS was 42 milligram per deciliter, LDH was 393. CTG was pathological with absent variability and late decelerations. Grave maternal and fetal prognosis was counseled and taken up for emergency lower segment cesarean section. In her intraoperative findings were mild to moderate ascitic fluid was noted, thick grade 3 meconium strain liquor was noted, Abgas were 0 to 4 and birth weight was 2.34 kgs. Uterine cavity, umbilical cord and placenta were stained greenish yellow in color. Intraoperatively, we transfused 1 unit PRBC and 4 FFPs. Post-procedure, uterus was retracted well with minimal blood loss and no evidence of PPH. Intraperitoneal drain was kept and she was shifted to MICU for further management. She was started on broad spectrum antibiotics. Post-operatively, she had recurrent episodes of hypoglycemia which were managed with dextrose infusion. And she had decreased urine output with metabolic acidosis. On post-operative day 2, she became tachypneic and developed tachycardia and also developed abdominal distension. Ultrasound abdomen was done and it showed paralytic ileus and polycerositis. Viral etiology of deranged liver function was ruled out. In view of fever spikes, drain fluid was sent for culture and sensitivity and antibiotics were changed based on culture report. Albumin infusions were given and adequate serum potassium levels maintained and later abdominal distension improved gradually. Intraperitoneal drain was in situ for 10 days with around 1 to 1.5 liter serous fluid for 7 days, which progressively reduced to minimal. Liver parameters were started to improve from post-operative day 7. Serial blood investigations were followed and she progressively improved. Patient shifted to room in stable condition and discharged 5 days later. Case 2. A 29-year-old gravida 4, para 2, live 1, death 1, abortion 1 with 2 previous cesarean sections with 8 months of amenorrhea. She was referred to us in view of BP recordings of 160/90, deranged liver function test and low platelet count. On general examination, patient was icteric, pallor was present and had pedal edema. Parabdominal findings were uterus was 32 weeks size, relaxed cephalic presentation and fetal heart rate was 110 on hand Doppler. Growth scan findings were 1 to 2 weeks growth disparity with severe oligohydramnios with signs of uteroplacental insufficiency and her vitals were BP 140/90, heart rate 112 per minute, saturation 96 on roommate. Her lab parameters were bilirubin was 6.4, elevated liver enzymes, platelet count was 1.1 lakh, INR was 2.92, serum creatinine was 1.9, uric acid was 8 and FBG shows mild metabolic acidosis. She was taken up for emergency lower segment cesarean section in view of severe oligo. Delivered a live female baby of weight 1.7 kgs with Abgar 689. Intraoperatively, we transfused 4 FFPs. Intraperitoneal drain was kept and patient shifted to MICU for further management. Postoperatively, she had recurrent episodes of hypoglycemia. On day 5 of LSES, she developed sudden hypotension and increased bleeding from drain site. CT abdomen was done and it revealed a hypodense hematoma of size 18 to 4 into 8 centimeters in the rectus sheath. She was taken up for emergency laparotomy for rectus sheath hematoma and hemoperitoneum evacuation under general anesthesia. There was almost 500 ml of rectus sheath hematoma and 2 liters of hemoperitoneum. In this picture, you can see the blood collected in the section container, and almost 13 mops were used during this procedure. She was started on inotropic support in view of hypotension, and ventilatory support was continued. During her hospital stay, we transfused 8 units of FFP, 4 units of cryoprecipitate, 1 unit of SDP, 4 units of RDP, and 3 units of PRBCs based on TEG report. Serial ABG, LFT coagulation profile and CBCs were monitored. Postoperatively, she had fever spikes and blood was sent for culture and sensitivity. Antibiotics were escalated accordingly and was started on antifungal medications. On day 11, fever spikes were continued. CT abdomen revealed intraperitoneal collection or hematoma in the pelvis. We planned for a conservative management after discussing with intervention radiologist and infectious disease specialist. On follow-up scans, hematoma was resolved. The patient had no further fever spikes after that. With team-based care and close monitoring, the patient is stable and her bowel and bladder functions were normal. LFT coagulation profile, platelet count and CRP were found to be improving and was discharged on 18th day in a stable condition. The differential diagnosis for about 2 cases were acute fatty liver of pregnancy, HELP syndrome, intrahepatic cholestasis of pregnancy, preeclampsia associated hepatic impairment. Based on Swansea criteria, the diagnosis of about 2 cases appears to lean more towards AFLP. 6 or more features should be present to diagnose AFLP based on Swansea criteria. Discussion. AFLP may be challenging to differentiate from HELP syndrome, severe preeclampsia, and may coexist at the same time. Liver failure signs like coagulopathy, disseminated intravascular coagulation, hypoglycemia are more typical of AFLP, which also shows higher transaminase and bilirubin levels. Management of AFLP and HELP syndrome preeclampsia involves early recognition, supportive care, and timely delivery to prevent maternal and fetal complications. Dr. Shilpa, our head of critical care department, will discuss differential diagnosis and management in further. Over to you, ma'am.